Well, the truth is y'all look better when it's darker. I'm just kidding, no, I mean, I look better when it's darker. Okay, this first lecture today, respiratory distress, as you'll notice on your canvas, I'm doing all the respiratory disorders first, then I go into cardiac. And what I'm doing this semester that I haven't done before because the previous classes have struggled so much is I have one full lecture dedicated to ECG review. Because so much of cardiopulmonary is you being able to look at an x-ray, an ECG, you know, an ultrasound, which I introduce, and be able to, with the vignette, make extrapolations and decide what the diagnosis is or treatment or whatever. So few little pointers that I want to point out. First of all, it seems in previous classes there's been a misunderstanding about what is stable or unstable as far as a patient goes. So do we want to take a stab at it? What's a stable patient?
Someone who's stats above 90.
Okay, so in just terms of oxygen saturations, not rate or anything, saturations above 90. I would agree with that. If you're satting at 90 or above, you're probably okay. We have to look at the patient now, make sure they're not tachypneic, breathing too fast, they're not going to go into respiratory failure. But if they're 90 or greater, that's probably not unstable, right? Give me another parameter that constitutes unstable. Like truly unstable. Okay, very low systolic pressure. So what you're telling me is hypotension. What is hypotension? Hypo. Any systolic below 90. Okay. What about that little old lady that only weighs 90 pounds? And she comes in, she gets her vital signs checked, she's 88 over 50 at baseline. Okay, thank you.
I was going to say, if the patient is symptomatic and how they're trending.
Okay,
So,
fair.
that little old lady that's hypotensive and that's her normal, she's not trending down and she's
Exactly,
not
that's where
symptomatic.
she lives,
But
right?
that, person that is younger or is symptomatic with the same readings, especially if they're getting worse, it's a little more unstable.
Absolutely. So trends are good, but initial look, if you only get one look at a vignette, what's unstable, ma'am?
What I'm thinking immediately is like if the patient's unable to speak full sentences to
Sure.
me, or they're
So that, like in altered mental status way or obstructed airway way, or either way?
I immediately start thinking about like COPD patients having an exacerbation.
Okay, so from an airway perspective,
This
they're so hard,
using
struggling.
muscles to
Sure, that is definitely unstable, I agree, okay? But on the same thing, just to piggyback on that, if they also are slurring or can't speak, just like you guys were so great at calculating the GCS, remember that test this morning? You guys were awesome, you nailed it. Okay, you actually were actually the best class, I think, at it. Any alterations of mental status in which they can't protect their airway is also unstable. Okay, what else constitutes unstable? Ma'am?
So if they're slurring their words like in the drug overdose.
Okay.
You can't pronounce them at all.
Okay, again, altered mental status, can't protect their airway.
Pinpoint people.
Okay.
Or blown out people.
Okay, maybe a head injured patient that's altered that had trauma, okay?
Any vitals that don't reflect their current system status. So
Exactly.
So if they just got in a car accident and they come in and are a little bit tachycardic, a little hypertensive, who cares? They just got in a car accident.
Right.
But if they should be tachycardic and they're sitting at 60, that's an unstable patient. If they should be tachypneic but they're breathing normally, that's an unstable patient.
So yeah, as you can see, there's a lot of definitions, right? And there's some confusion. Okay, so I'm gonna try to sum it up, and it does depend on your patient presentation and with the situation. If you have a post-trauma patient that's tachycardic in the 130s and they just sustained trauma, they're probably unstable, right? That's probably a blood loss situation, okay? But normally, if somebody has a fever, like the flu right now, and they come in with a 104 fever, can their heart rate be in the 130s? And they're perfectly stable. So it's all about perspective, but I just I wanna draw a line here, okay? And to eliminate confusion, okay? Anything under systolic of 90, okay, in the face of something like sepsis, trauma, blood loss, that's unstable. If you see hypotension, systolic pressure of 90 or less, coupled with tachycardia, okay, a heart rate over 100, that patient has probably got something significant going on. That patient is unstable. Any hypoxic patient, SATs under 90, needs some sort of support, okay, whether it just be nasal cannula O2 versus, they're satting at 60 and needs to be intubated. That's a form of instability. So for a respiratory rate of 28 or greater, okay, they're so tachypneic, they're gonna start blowing off their CO2, they're gonna have respiratory failure. So what are those things that I'm describing, those individual parameters, what are those all a part of? Those are vital signs. Thank you. Vital signs are vital. Okay. Now, systolic pressure of 180, we know that that's high, right? But guess what? 80% of elderly Americans, might walk around with transient blood pressures, and they're not unstable. So, use some common sense. Don't get yourselves tripped up. But hypotension with tachycardia or low sats is unstable, okay? And I'll try to clarify that a little bit so that you guys aren't confused. Okay, anybody confused already? I don't think so, even though it's a Friday afternoon on test day. Okay, usually I use Titnelli. Does anybody have library access where they actually access books and look at it? Do you guys actually get into a textbook ever? Okay, and you don't have to for my stuff. I put everything that you need to know in the PowerPoint slides or out of my mouth, okay? That's it. There's no tricks, all right? Okay, so this is some of the stuff we're gonna talk about. What I usually do in my lectures is I talk about the topic. I talk a little bit about a pathophys. I tell you we'll do a warm-up case, and then I'll usually say these are the top 4 things you've gotta do to somebody that's presenting with this that's unstable. Okay, and then I'll kind of go a little bit into pathophys, the patient presentation, your workup, treatment, and disposition. Okay, does that make sense? Is that kind of a logical stepwise? Sometimes we get to a point where we know what's going on, but we don't know what to do with them. Okay, so we're going to try to clarify that as well. So in the ER, I don't know if Colonel Gendron talked about this, we usually have a safety net. Okay, we do. We want almost every patient, unless they're a quick in and out flu or full throat swab and go, if they come into a bed, the nurse puts them on a monitor. So we have IV access, O2 monitor. Does every patient need an IV? Does every patient need to be on a monitor? And does most patients, do they need oxygen? Probably not, but this is our safety net. So if we think somebody's super sick or they're unstable in their vitals, these are the first things we're asking is our ED safety net. So you gotta put on your hats right now and pretend you're an emergency medicine PA. So if they're unstable or super sick in any way, we're gonna do an IV O2 monitor, okay? It's our safety net, okay? All right, so critical patient. So if you know the alphabet, you know exactly what to do, right? What always comes first unless it's trauma? Trauma's different. This is just medicine. It's always the ABCs, right? Okay, airway. All right, we talked about this already. I know you guys know this already, but and some of you described it already. How do we know if somebody can protect their airway? I'm sorry? For talking. Is that what you said? Yeah. If you can phonate, that's complex neuromuscular activity. If you can phonate, you can definitely have and protect your own airway. Okay, is gag reflex a good, reliable indicator of airway? Anybody ever see those little weirdos that don't have a gag reflex? I'm sorry, there's 1 in 4 people, so there's several of you, I'm not judging you, okay? Just statistically, 1 in 4 people don't have much of a gag reflex, okay? So that's not a reliable indicator. So just sticking a tongue depressor in someone's mouth, okay, I know y'all are going to a different place, and I'm not trying to be dirty on a Friday afternoon, okay? Or get fired today, I got till February 28th, okay? But that's not a reliable indicator, okay? What's another thing for airway that we can tell by just looking at them that they can control their airway? Well, we said talking, phonating, true. What else?
General appearance.
Okay, no accessory muscle use. Okay, that's kind of breathing, but still, they're swallowing their own secretions. Okay, they're not sitting there drooling. Okay, if you can swallow your own secretions and you can phonate, you have a patent airway, you or your patient. Okay, breathing. Okay, what are some indicators that somebody's not breathing well? Accessory muscle use, tachypnea, which means fast breathing. What else? Yeah, you hear all kinds of weird sounds. Maybe they're posturing, they have stridor, wheezing. Okay, those are bad. Okay, circulation. How do we know if somebody's has adequate circulation? You can do a quick cap refill, check pulse in all 4 extremities. What else? Color of the patient. What else? For circulation. blood pressure is an indicator of circulation. So sometimes not only do we check for, like in the military, radial pulse and mentation, but if they have a systolic pressure, radial pulse, they usually have a systolic pressure equal to what? 80, 90, something like that, usually. It's not an absolute science. And then disability, which you guys have already learned, if they're able to tell you alert oriented or whatever, that they probably have a GCS of 15, right? All right, let's move on. I'm trying, this won't let me move on. I don't know why. Okay, so let's do a warm-up case. Do you guys want to read it yourselves or you want me to read it? I think you should read it yourself. Come on, we're having fun. It's a Friday afternoon. Let's do this. If you think that's a long vignette, the pants exam is like twice as long. They're so ridiculous. I'm angry every time I have to recertify. All right, what do you guys think about this? So we have a 72-year-old, worsening dyspnea, has some significant history, right? Hypertension, heart failure, COPD, occasionally uses, you okay? Okay, occasionally uses home oxygen. What does that mean? That means that patient's probably non-compliant, right? Probably always supposed to be on oxygen, but probably only uses it sometimes, okay? Right now, these are the vital signs. Blood pressure 144/80, heart rate's 96, 18 respiratory, 8 febrile, sitting at 94% on 2 liters, okay? Anything about that vital signs seem unstable to you? No, there's some abnormalities, right? A little hypertense, a little it's not over 100, but but there's nothing unstable about that, okay? The question is asking, okay, you see pitting bilaterally, what labs would be the most useful in confirming the diagnosis? What labs are we thinking about, somebody who's presenting like this? Worsening dyspnea, what's our differential? Give me 3. COPD exacerbation? CHF exacerbation?
Pulmonary edema.
Okay, pulmonary edema, what else?
Just heart failure.
Yep, CHF exacerbation, what else? Are they complaining of chest pain? Nope, he says no chest pain. So probably not ACS, but you could have an atypical presentation. So you guys gave me 3, just like you told, I asked you, so good. Now what lab would help us determine, is this more COPD or is this more CHF? A BNP would be fantastic, right? Is that a slam dunk? No. And then sometimes you have to know what their baseline is. Okay, so if this patient was critically abnormal, like with their vital signs, first thing we're gonna do is protect the airway, all right? So we're gonna assess for airway. And if they don't have a stable airway and we decide to intubate, you gotta be careful with these folks. Because if they're having a CHF or a COPD exacerbation or they're septic, once we sedate and paralyze them, they'll crash, they'll go into cardiac arrest. So make sure that you don't sedate and paralyze a hypotense patient because they're just gonna get worse, okay? So a little life curl for you. Okay, if you have to secure the airway by intubating, just make sure that they're well hydrated, meaning that you're giving them fluids or pressors if necessary. Breathing, how can we help them with their breathing if they're having tachypnea and accessory muscle use? How can we help them? We can give them some oxygen, that'd be nice. What else can we do?
They're anxious, we can take care of that.
What's that?
They're anxious, we can take care of that.
Okay, so maybe, are you talking about like maybe a little Ativan or something like that to calm them down?
Maybe not for each person, but
Okay, sure, I think that's fair. Sometimes we have to do that. What else? Position in the patient sometimes. BiPAP would be fantastic. Okay, we'll talk about BiPAP. That's putting them on kind of high flow oxygen. So nasal cannula, non-rebreather. We can use BiPAP, things like that.
Diuretic for the edema.
I'm sorry?
Diuretic for the edema.
Yeah, that'd be great. All right, let's give them some Lasix or something, take some of that fluid off. All right, we'll talk about that as well. Circulation, how we help support that is making sure we have access. And if the patient's hypotense, we give them fluids if they're not CHF type patient. Or if they're septic and we have to put them on pressors, we're gonna help facilitate adequate normal circulation to keep their MAPs normal. And then lastly, we need to do a GCS on them. We wanna make sure they're mentating, because if their GCS is low, they could be hypercapnic. What does that mean? High CO2, right, which can alter somebody's mental status. Very good. This is only, well, it says 40 slides, but we're gonna get through this super fast, and we're gonna have an awesome weekend, okay? You guys don't have an exam until when, next Tuesday? Okay, awesome. So, how would y'all describe, what is dyspnea to you? What have you learned before?
Shortness or difficult breathing?
Yeah, difficulty breathing, shortness of breath. It's usually what our patients tell us. I've had patients come in and say, I can't breathe at all. And then they're just candy crushing, right? I mean, that's probably not my definition of dyspnea. So it's usually what the patient tells you. Shortness of breath, breathlessness, and it can be caused by cardiac, pulmonary, a number of other diseases, but those are the top two reasons. And some people will actually tell you when they feel short of breath. Is it just at rest? Is it when you exert yourself? Is it when you lay down? Okay, is it after you just got off a flight from Malaysia and you were just diagnosed with pregnancy, but you broke your femur as you were coming off the tarmac, or, you know, I mean, that patient's highly unfortunate and probably has a PE, right? It was a sudden onset, that kind of thing. Okay, tachypnea, y'all know that, what that is, right? What is it? Yeah, how fast? Over 20, right? So if somebody's breathing 22 and they're mildly tachypneic, they're pretty stable, okay? All right, PND, you guys know what PND is, right? You had cardio. What is that? Did you guys learn paroxysmal nocturnal dyspnea? Who gets that? CHF people a lot of times, because they have, yeah, and sometimes COPDers, and then of course, I don't know if you've noticed here in San Antonio, but we have HED, and we have patients that have HED body armor on them. Do you know what that means? They're carrying a little extra weight, right? Which helps if you're in a knife fight, because you get stabbed like 50 times, but a single vital organ's not actually penetrated. But it doesn't really help when you try to lay down at night and sleep, right? Okay. All right, respiratory distress is something we usually say. We say, hey, we think that patient's in distress. And we're taking it all in. We see that they're, maybe they're drooling, maybe they're accessory muscle use, maybe they're tripoding, maybe their SATs are low and their respiratory rate's high. And then lastly, they'll go into failure where things just don't work, okay? And that could be because of oxygenation or a ventilatory problem. Okay, you guys agree with me? I'm losing you, you're fading. Okay, I say that a lot and then it makes the critique go, we're tired, I'm seniors, you need to stop saying stuff. I can't help it, this is just me, okay, I can't help it. I try to keep you interested, okay? So I say dumb stuff when there's a, you know, when there's like uncomfortable pauses, okay? So that's just who I am, I can't get over myself. Okay, so what causes dyspnea? Well, it's usually a bunch of different little mechanisms. So some of them are sensory information from like afferent type signals. Some of them are due to an imbalance in the inspiratory drive. So as our CO2 levels increase, things like that. So here are the most common causes of dyspnea in the emergency department. What would you think just off the top of your head would be the number one cause of dyspnea? Asthma is pretty prevalent here in the United States. That's probably one of the most, and then followed by COPD, heart conditions, right? CHF, people have had coronary artery disease, things like that, cardiogenic pulmonary edema, ischemic heart disease, pneumonia. Right now, I've probably diagnosed 55 cases of flu A just this week alone. So they're like, I can't breathe. You know, I mean, you feel lousy, right, when you have the flu. So those are pretty common. Life-threatening, we're thinking foreign body, we're thinking tension pneumothorax or spontaneous pneumo. What else can cause sudden shortness of breath? Anaphylaxis, a giant PE, acute coronary syndrome, you know, stuff like that. You know, sometimes a fat embolism if they had surgery, things of that nature. Okay, so most of the time people have kind of an insidious onset, a slow onset of shortness of breath. If it's sudden, you got to think about those terrible emergencies. Most things are not sudden. Like Colonel Gendron just taught you about head bleeds, sudden onset. It's not that gradual, it's like sudden onset when I was working out or exerting, that kind of thing. Same with cardiopulmonary. Sudden chest pain is dissection, ACS, PE. Sudden shortness of breath is pneumothorax, PE, something like that, okay? Sometimes we can see them, there'll be nasal flaring, accessory muscle use, all the stuff you already know, right? What does a patient look like when they're really working to breathe, besides the accessory muscle use, the tripoding, the nasal flaring? Do you expect them to be warm and dry or diaphoretic?
Diaphoretic, pale,
What's that?
is it diaphoretic pale?
Yeah, usually. It depends, right? It depends on the cause, but sometimes. So when we're trying to work these patients up, it's important that we do a thorough history, right? You guys have been learning how to do a history. Did Karen Salyers teach you how to do medical history? Do you know how every single question in the universe to ask, okay? We're gonna do a H&P, and we can kind of conclude the diagnosis by a good history and a quick physical exam. So obviously, we're gonna assess their airways like we talked about ABCs. And that's kind of important. We're gonna stop at any point and address those abnormalities if necessary before we move on. And we talked about these things already, ABCs. But if they're hypoxic, we're gonna give them oxygen. We talked about some of our options. If they're just complaining of dyspnea, we gotta figure out their underlying comorbidities, medication compliance, things like that, okay? Remember that dyspnea is a prominent feature of heart failure. Okay, so it's not all that wheezes is asthma. Sometimes it's heart failure, sometimes it's vocal cord dysfunction. It's kind of hard to tease that out sometimes. But if you ask enough questions, you'll get the answer, okay? You'll understand. Okay, so what are some diagnostics? How do we help work these patients up besides the BNP that we talked about? What are some other things that we can do to work up a respiratory distress or a dyspneic patient? Yeah, we can do a pulmonary function test. I'll be honest with you, we don't do those very often in the emergency department. Now, if you're in a family medicine, that's absolutely the right setting. Usually if they come into the emergency department and they're complaining of dyspnea, they can't really participate in PFTs, unless it's mild, okay? But if you are able to obtain one, it's fantastic because we can do a pre and post treatment, like maybe it's a mild asthma exacerbation, we can do a PFT on those. But what are some other diagnostics that we can do in the emergency department? If you had all the stuff right at your disposal, what are some things we can do?
Chest X-ray,
You can do a chest X-ray, okay, that'd be good.
EKG.
ECG, good. A VBG, a venous blood gas. Thank you for not saying ABG, okay? You do not have to do arterial blood gases to get the information you need. You can do venous. Okay, if you're in a critical care ICU and there's something very specific going on, they may do ABGs, but by and large, a venous blood gas gives you all the information that you need. Okay, what else? Yeah, if they have to, sometimes you gotta elevate the imaging to a CAT scan, okay? What are some other diagnostic things to help us figure out about dyspnea complaint or respiratory distress? Yeah, we have bronchoscopy and tools like that in the emergency department now, or also in some of the wards. So you can bronch somebody, maybe they have chronic lung disease or cystic fibrosis, and you want to see if there's a giant mucus plug or something like that. What else?
A D-dimer.
Yeah, physical exam, that you auscultate with your stethoscope. You know the stethoscope, what year it was invented? Me neither. But it was one of the earliest bedside technologies you could ever do with a patient, okay? And it's not really changed much. Other than ultrasound, there's nothing else you can do right at the bedside to help diagnose patients. Okay, so you said some of those things, right? ECG, troponin, maybe a CBC, chemistry. Why would a CBC be important for someone who might have dyspnea? Maybe they're severely anemic, and maybe they're dyspneic because they're anemic and they have a GI bleed. What about a D-dimer? Would that be helpful in some instances? Sure, if you think PE is on the differential, we'll talk about that, okay? So it kind of depends. So just look at this chest X-ray, kind of grabbing the crypts of your brains back to your sophomore semester when Colonel Johnson just crushed you in radiology. Was it him? Just, oh, was he nice?
No.
Grabbing the crypts when Major Passion crushed you in radiology, okay? This is what, you remember what this looks like. I appreciate the honesty. See, what I try to treat you all like future colleagues, so it's an honest, professional environment. So what do we see here? That's a term called suit, right? This lady has something up in there, okay? And what that something up in there is fluid all around the lungs where it shouldn't be, right? Plus a big old water bottle heart, that's an acronym, that's a medical acronym, it's really important, something up in there. Okay, so she's got alveolar edema, she's got an enlarged heart, which means that she's got cardiomegaly, so she has CHF with pulmonary edema. That's helpful, right? That's good stuff. We talked about chest CT. Here are some indications in which you might want to elevate your imaging to a CT, especially if you think it's a PE or an aortic dissection. If maybe you can't really see the pneumonia on a chest x-ray, but the patient's super critical, and you think maybe there's some other lung pathology going on, and you end up diagnosing pneumonia. I would argue that you should not have to diagnose a pneumothorax by chest CT because the bedside ultrasound is so accurate. I'm going to teach you guys how to do it. And in lieu of being fired on February 28th, I think we're going to move up ultrasound block next. Don't let it blow your mind. It's going to take the exact same amount of time as EMED 3. So instead of it saying EMED 3 on your, it's just going to say EMED 5. And we're going to go right to ultrasound, which is super cool. So I can do fun stuff before I'm not here anymore. Anyway, pneumothorax can be diagnosed by bedside ultrasound. Pulmonary edema, sure, if there's like a large pleural effusion or an empyema or something. Rib fractures sometimes are hard to see on chest x-ray, so it's fair to maybe have to do a CT. And then, of course, contusions. We talked about most of these labs. Any labs on here that we haven't already talked about? Oh yeah, POCUS. That's point of care ultrasound. It's not a lab, it's the imaging part. And I'm going to teach you guys how to do some bedside ultrasound stuff to help you with your patient that's complaining of dyspnea. Pulse oximetry, is that helpful?
Yes.
You guys know about that, right? What does it tell us? The saturation of oxygen, right? How accurate is it, like breath to breath? How long does it take for it to adjust? Was anybody here at RT before? Yeah, I thought you said that. How long does it take for it to adjust?
Sorry, when you place it on the finger, I would say not even 10 seconds.
Let's say a patient acutely decompensated. How long would it take for the pulse ox to reflect that sudden change?
Actually, it's kind of quick.
Fairly quick, right? It can take several breaths, 6, 7, 8 breaths. I mean, it can.
Not like a minute.
Hopefully not.
Definitely less than, yeah, like less than 30 seconds.
Okay, we're gonna go with less than 30 seconds, but it couldn't be 30 seconds. It could be 29.9 seconds. Okay, so great. Then we have end-tidal CO2. Have y'all seen the end-tidal CO2 monitors? Where'd you guys see them? In pulmonary medicine, they showed it to you? You guys were obviously in different classes during that time? Okay, well, this is what an end-tidal CO2, there's all kinds. This particular one's called the EMED. This is what we use in pre-hospital now, and you guys will actually get to do it during your ATM lab. And what I love about the end-tidal CO2 is it tells you breath by breath, not 29.9 seconds, like instantaneous, whether the patient has changed breath to breath. So what's important about the end-tidal is that numerical number that's displayed, that's their CO2 level. Now I'm going to give you a little caveat. That's the minimum amount of CO2 that they have. In other words, this patient may have a CO2 really of 70, but it's definitely not less than 39. And you'd be like, well, that's confusing, but it isn't. It's important. But also even more important than that numerical display is this little waveform. Have you guys seen those before? It looks like a little, kind of like a little rectangle. That waveform will tell you breath by breath changes. And the reason why this is important is I saw a patient not that long ago, intubated pre-hospital by paramedics, confirmed by all their different methods of confirming. They confirmed by end-tidal, which is supposed to be the gold standard. Okay, end-tidal is the gold standard. They secured the airway, brought the patient in. Patient comes in, they have a numerical display of like 35, which is totally normal, CO2 level 35 to 45, but there was no waveform. I was like, something's off. Like, what's that? Yeah, you would think, but you'd see some waveform, even if it's in the right main stem. So I was like, something's not right. So I just grabbed the glide scope and I kind of looked in there. The tube was actually in the stomach, but the patient was awake enough and was breathing spontaneously around the tube that was in his stomach and just happened not to vomit. So the end-tidal was picking up the CO2 level, but without the waveform, it told us that the endotracheal tube was not actually in the trachea. So it's very important, and what you'll see when you guys do the ATM lab, which is super cool, is that this number will go from 30, actually usually the K primes are like 70, it'll drop to like 14. That means that the K prime just went into cardiac arrest. Okay, so it'll give you breath by breath changes. It's very important. I use this all the time, especially if I'm intubating or doing any kind of airway management, but I also put it on my septic patients, on anybody that I'm doing a conscious sedation or a procedural sedation, a joint reduction or a fracture reduction. Everybody's on end-tidal so that I know, hey, you get too much propofol in patients, apnea, you know, you can see everything, okay? Are you guys okay? You getting squirmy? A little bit, okay, I'm gonna go fast. Am I talking too fast? Am I talking too slow? It's a Friday afternoon, I'm talking too slow, right? Okay, but I don't wanna lose anybody. But anyway, all of these things we talked about already, and I'm also gonna introduce you what point of care ultrasound looks like. We talked about PFTs, also known as bedside spirometry. Again, it's not a skill we do in the emergency department, but as family medicine PAs, it is a skill you should know. You can do a pre and post-treatment peak flow, and as long as they're greater than 70% of their predicted, that means that they've improved, and they can usually be reliably sent home, okay? Really helpful for like asthma, COPD, mild exacerbations. I'm gonna give you a bunch of pictures now of a bedside lung ultrasound, and this is something that we're gonna teach you. The benefit of POCUS, point of care ultrasound, or bedside lung ultrasound, is that you can identify fluid in the lungs, pneumothorax, cardiac tamponade. You can see if there's any other wall abnormalities of the heart. In other words, if there's a dilated right ventricle, that person has a ginormous PE. You can see if they've just had a giant MI, because there's wall motion abnormalities or a dilated cardiomyopathy. You can see all of those things at the bedside. And then you can actually check their intravascular volume status. Okay, what does that mean? And I thought we'd go, you know, it's like, usually it's like 30 minutes. If I can talk fast in 30 minutes, I still have your attention. But I can see you fading, and it's not your fault. It's what we do to you here at IPAP, okay? We make you sit here all day long, all week long, receiving PowerPoint presentations. My question was, what does it mean when we check for intravascular volume status? What does that mean? Yeah, their overall fluid. Are they in fluid overload, or are they dehydrated? Is that hard to discern sometimes in certain populations of patients? What about the CHF people that always have fluid, but they're still septic? So their legs are still swollen, their lips are dry, and you're like, do I give her fluid? Do I not give her fluid? You can do a quick bedside ultrasound and look at their inferior vena cava, and you can tell if it's fat or not. So this is a lung exam, okay, and we're going to teach you this. This is where we're putting a linear probe in between two ribs on the anterior chest, second intercostal space, mid-clavicular line, and we're just looking at the lung. We're looking at lung sliding, okay, and we're looking at that white stuff at the top is the lung, right here. This is the pleural space in between the two ribs over here. And all this ring down shiny stuff that looks like shimmerings, that's all indicative of fluid. And if you see 3 or more of these little flashlight looking ring down artifact in one window, so this is one window, if you see 3 or more of those in one window, that's significant for pulmonary edema. Would we all agree that there's more than 3 there? So this person has significant fluid in their lungs, okay? So we can also see static and dynamic bronchograms. I'm not going to make you guys do that. Just to back up a little bit to the last slide, this is called an ultrasonic B-line. Okay, have you ever heard that term before, B-line? So in ultrasound, they're vertical artifacts from fluid. Haven't you guys heard of curly B lines before? Anybody remember what those are? Yeah, they're horizontal lines, also indicating fluid, right? So they kind of match, similar. Okay, BNP. We talked about BNP. It's useful if we're evaluating for dyspnea. It's just trying to tell us, is there a heart failure component to whatever the patient's presenting with dyspnea for or not? What would be a good number to tell us, hey, yes, there is a CHF portion of what's going on with this patient? Do you guys remember BNP numbers? That's okay, we'll teach you. So there's regular BNP, pro BNP, so that we'll talk about that. So usually if it's less than 100 on the regular BNP or less than 300 pro BNP, there's no CHF. If it's greater than that, they have some form of CHF, but you can't just say, yes, it's a CHF exacerbation because their number is 350. Now we have to compare it to an old BNP level in order to see where that patient's baseline is. Does that make sense? Okay, I'm gonna go through the rest of these fairly quickly. We talked about D-dimer. What is D-dimer helpful in diagnosing? There's actually two conditions that we use it a lot for. One, PE is the most useful, and sometimes people will do a D-dimer looking for aortic dissection, okay? It almost always is positive in a dissection, okay? All right, moving on. Okay, we talked about history, how the patient might present, some of the things we're looking at with vital signs, some labs and RADs and bedside ultrasound things we can do. How are we gonna treat somebody that is having dyspnea? We talked about most of this already. How would we treat these people? Support their ABCs, right? We're just gonna support their airway, support their breathing, give them some oxygen if we have to. Support circulation with fluids or not fluids. Maybe we have to take fluid off of them so they can breathe better, okay? Does this seem like a review to you? Mostly? Okay, maybe a few new concepts, but mostly the same. We talked about hypoxia and hypoxemia a little bit earlier. By definition, hypoxemia is when the PaO2 is less than 60, which correlates with a pulse oximetry of less than 90, okay? So synonymous terms, they're actually a little different though, but that one talks about alveolar, but anyway, I'm not gonna make you split hairs on that. Just know that a PaO2 should be greater than 60, or pulse ox, which is an SaO2, should be greater than 90. Some of the clinical features of hypoxia or hypoxemia are things that we've already talked about: dyspnea, tachypnea, agitation, tripoding, accessory muscle use, things like that. There's a few conditions that you should be aware of that might give you false normal pulse oximetry. Does anybody know what some of those are? Carbon monoxide poisoning, and there's another one.
Cold.
Yeah, yes, that's right there. It's awesome. Hemoglobin, or carboxyhemoglobin, both of those. So you can have, because it binds to oxygen or the red blood cell, the hemoglobin a lot easier. So sometimes they'll overestimate. So any patient that we see at Ramsey that came from like a house fire, the first thing that we do is we get a carboxyhemoglobin level on them because we could be falsely reassured that their pulse ox is okay. All right. Anyway, regardless of the cause, we make sure their airway, breathing, and circulation is supported, as we do with every kind of medical patient. Hypercapnia, we talked about earlier, can cause altered mental status. That's anybody that has a CO2 level of greater than 45. Where do we think some of our COPD patients live at? What's their baseline CO2? What do you think?
40.
Yeah, it could be 70. What else? It could be anything over 45. It could be, some people live at 80. I saw one guy come in, and we're gonna talk about this in a couple lectures, but I saw one guy in, he looked like your typical blue bloater. You know, he probably weighed like 250, and he was heavy, kind of had that blue ashen look. Chronic COPD. We did a quick bedside BBG, and his CO2 level, the top that it registered on the BBG, do you remember what the top CO2, I'm gonna keep picking on my respiratory therapist, man. I know, you don't mind, do you?
No, I don't.
Okay, thank you for imparting your knowledge on the class. What is the highest CO2 level that's detectable on the BBG? Do you remember? It's not to sharpshoot you, it's because I truly don't remember. I think this guy said like 120 or something ridiculous. And
I mean,
yeah, I don't think it went higher than that.
CO2 120?
Yeah. I know. So that's really high, right? So that's, even she's impressed, okay, with my CO2 level. So I think that was the highest the lab would read on the portable venous blood gas. And when I told some of the folks that I was working with, like, hey, this guy, because we're at shift turnover, of course, is when you pick up a terrible patient who's right at shift turnover. I was like, hey, his CO2 is 120, and it actually said greater than, because that's the highest that the value would go. So everyone went running in there thinking they were going to intubate him because it's a really high CO2, and he was just mentating, talking. I mean, I think he was admitted, and like 36 hours later, he was intubated because it kept rising. But, we always treat the patient, not the monitor, but that's a pretty high level. So that's not normal. Normal COPDers though could live around 70 or 80 every single day, okay? Here's some causes of high CO2 levels. A lot of times it's not just COPDers, it can be other things, drug-induced, things like that. And just a little pathophys on it, a lot of times it causes decreased respiratory drive. And so they could have a CNS lesion, they could have kyphosis, they could have a number of conditions which are summarized in the chart before this one, okay? You do not have to memorize that, this is for background information. Signs and symptoms of increased CO2. If somebody lives at 80 and their CO2 is 80, do you think they're gonna have any acute signs of CO2 increase or hypercapnia? No, it's not really the number, it's the rate of change. So that's why that guy I saw had a hypercapnia CO2 level of 120 and was still mentating. He probably lived at 90 or 100 for a long time. It's the acute changes that causes altered mental status typically, or an abrupt change, okay? All right, we diagnose that by ABG or BBG, usually BBG, or we can do a CO2 measurement, end-tidal CO2. Serum bicarb, do you guys remember talking about this stuff? CO3, what's a normal level of bicarb? Yeah, 22-ish. You know, each hospital will vary by a point or two, but yeah, 22-ish to 28, depending on who you read. Great. These are some normal parameters just for your edification of a blood gas. Usually our pH in our bodies are 7.35 to 7.45. You guys know that, right? Our CO2 level is supposed to be between 35 and 45. Okay, in a VBG, this is normal, 36 to 42 oxygenation, and an ABG would be closer to 100, okay? Bicarb 22 to 26, and does anybody know what BE means? It's a base excess, that's right. And so that's helpful when we're doing like resuscitating a trauma patient or a septic patient. BE means base excess, meaning if you have a positive number, a lot of times that can be indicative of being kind of fluid overload. All right, we see people with base excesses of 8, 10, or especially if we have to do a paracentesis and take fluid off somebody, it can be even higher. But in trauma, the opposite is happening. When they need blood and their lactate is high, we call this a base deficit once it's a negative number. And if they come in a trauma patient, they have a base deficit of 10 or more, that might indicate that this patient needs a massive blood transfusion. So that base excess becomes a deficit if it's a negative number. Does that make sense? Okay, am I saying it right? Right? Just give me a thumbs up every now and then. Everybody likes affirmation, okay? So just, yeah, even if it sounds, let's talk offline, okay? If I mess up something. Okay, how do we treat hypercapnia or high CO2? We're almost done, and then you have a long weekend. And then what's your test Tuesday? Okay, all right, so how can we treat high CO2 levels? That doesn't get me on camera making faces, right? No, okay. Sorry.
Increase respiration.
That's right, increase the respiratory rate, increase the O2, okay, or total tidal volume, make sure their airway's patent. Pretty simple stuff, right? We support them. All right, BiPAP is something that I love to start patients on. Did you guys talk much about BiPAP in pulmonary medicine before? So it's basically a bi-level positive pressure, so they're constantly getting pressure, and and when you get to phase 2, I encourage you to put one of these masks on. I'm somebody who likes to scuba dive and stuff like that, but this thing made me anxious, okay? It's a tight mask and it just forces this high pressure of air, and then it gives you a moment to kind of off gas, but it's still continuous pressure. So we've set it at like a 12/5 or an 8/4, meaning that when you inspire, the pressure's higher, and then it allows you to expire a little bit, but it's still giving you a lot of pressure. And it helps support people, it helps recruit alveoli. This is how during COVID, we kept people from being intubated, or COPD and asthma patients, we keep them from being intubated by doing BiPAP. We don't want to intubate those people, because once we do, we can't unintubate them, right? It's hard to extubate them once they become intubated. But anyway, these masks are tight, and the patient has to participate with breathing in and out at the time that the machine does in and out. And so it's kind of anxiety provoking, and if you're already kind of not breathing well and you're a little anxious, this might be one of those times you need a little benzos or something to kind of calm them down a little bit so they can help breathe, not enough to cause respiratory depression, but just enough to calm them so they can participate in BiPAP. But this is what it looks like, and it drives the pressure to maintain adequate tidal volumes for a patient. Okay, disposition. What do we do with a lot of these people? Well, it depends, right? Do they fully recover from whatever they came in with their respiratory distress? Did you fix them? Are they back at their baseline? And you can send them home? Do they still need some oxygen support? Are their gases improving? Are their CO2 levels normalizing for them? You know, are they, it just depends on the patient, okay? And so let's go through one check on learning. I know you're ready to go. I saw some laptops close. You guys are optimistic, and just like I will the rest of the semester, I'm gonna crush your dreams. I'm gonna talk for a few more minutes, okay? Let's go through one more case. You guys like these check on learnings, right? It's your favorite, because these are how I ask my questions. So if I highlight something or put something in red, or have something check on learning or critical, that's probably good, useful stuff. This is a long vignette. Who wrote this? This is terrible. Okay, go ahead. Tell me what y'all think after you read it. Okay, what's the differential? Okay, CHF exacerbation. Okay, mass. What else? You gotta at least get 3. Even for clean core, you gotta get 3. Right? Okay. She could be alcoholic cirrhosis for sure. So she has a history of ACS. Yeah, heart failure. What else? Did you say COPD or did you say PND? Which is indicative of? Right. Okay, could be septic, right? Even though they're not febrile, not tachycardic. Oh, she is tachycardic. Okay. Yep, she can totally be septic. That's us. Just give me some differentials. Come on. What's her history? MI? So could it be an MI? Okay, good. Diabetes? Could it be DKA? Who knows? Maybe. Okay, what else? Could be a pneumonia, could be CHF, ACS. Okay, good. You guys nailed that. That was awesome. Okay, so what do we think? What's the most likely cause of this patient's symptoms? It's probably CHF, right? She's all that getting edema, all that fluid, she's tachycardic now. Okay, not enough information. So I'm not going to ask a question like that. I'll at least give you a chest x-ray or a bedside ultrasound or something like that. I just want to start getting your wheels turning. Are there any questions about this introductory lecture? Are you cool with the pace? This is how I go every single time. Okay? So if one of you or some of you need, like I'm going too fast for you, I'll make time for you, no problem. I'll break it down and kind of point out what, any questions that you have. I'm an honest broker. And then at the end of this block, I like to give a little Jeopardy review game, as long as you're competitive. Are you a competitive class? If you're not, it's boring for me.
I do have a quick question.
Yes, ma'am.
Sorry guys, I do have.
Yeah,
today, oh, sorry.
it's easy to get angry as a senior, I'm just saying.
Today we learned in GU how kidney, chronic kidney disease can lead to heart failure and heart failure disease not. So I started also thinking maybe a kidney issue but the backup of fluid.
100%.
So I was on the right track.
Absolutely, there's a broad differential. And so that's why you can't really hang that's what most likely cause given, all the fluid overload that this patient is exuding, but it can be caused by lots of different things. So just want you guys to start thinking, but I'll start giving you more nuggets of information as we throughout the block. Y'all enjoy your weekend, your 3-day weekend, or few and far between.